I'm a practicing psychiatrist. I'm also professor of neurotechnology at the University of Cambridge here at Chemical Engineering and Biotechnology, just off Mattingly Road. A little bit of a strange combination. I'm still seeing patients as an honorary consultant psychiatrist, but if it is unclear whether someone has bipolar disorder or depression, particularly if they can't give a clear history of previous manic symptoms, this test could point in the right direction. And we are at the moment sort of starting a study to validate these findings. So this is very exciting to us, has been a major step. And then I want to just also talk to you and tell you about the follow-up results, which were very interesting. So it's the perceived usefulness of the study and what aspects patients found useful. And you can see here, patients who received the report of their potential diagnosis said as a consequence of doing the study, they were talking more openly to friends and family about their symptoms. They felt they understood their problems better themselves, and they were more proactive at seeking help in other aspects as well. And the aspects of the study which they found particularly important were the results. It was the personalized psychoeducation and was also self-help advice. And we found from the 1,300 participants and feedbacks we got that about 16% of patients changed their diagnosis. Those who were previously depression, now I think it's 8% who had a new diagnosis of bipolar disorder, and obviously quite a number of the patients with depression lost their diagnosis. And we could also see that in their reported medication, that patients had done our online assessment. They went to their GP. The GP probably referred them to the psychiatrist, and then their diagnosis was changed, and also their medication was changed as a consequence. So this was very positive. And the most encouraging aspect for me was when we looked at the well-being scale. So patients just did this online questionnaire, and then they received a minimalist report under ethics. We could not go into too much detail, and some personalized psychoeducation. And when we did the well-being scale, where we looked at people's functioning, their well-being in everyday life, their function in everyday life, we saw a significant improvement both after 6 and 12 months. And this is as strong as if someone has had 16 sessions of psychotherapy. So just this report, people were talking more openly about how they feel. They were seeking help. They felt more validated in that, I can talk about it. I'm not a strange person. I'm not wrong in any way, but I'm suffering from a condition. I understand it better, and therefore I can seek help. And then as a consequence, they feel better and feel that they are not lacking. And I think this is very, very, very important aspect. And then on the basis of this study, we already sort of at the beginning have incorporated a new company, Siomics. We are trying to help every patient onto the right pathway. Not only people with depression, bipolar disorder, we want to identify problems, and we want that people receive the most appropriate help early on. So Censeo has grown from the Delta study to a larger platform. We're now over 1,400 questions, non-linear delivered. We're assessing more conditions. It's a digitally delivered platform. At the moment, the biomarkers are not incorporated. This may come later. It's a series of adaptive questions. It's built on detailed picture of someone's holistic presentation about how often do you see a friend, how often do you talk to someone that you feel close to, because all of this is very important for mental health as well. It's how someone feels supported in their environment. If someone says, I only talk once a month or never to someone that I feel close to, that's not a very good sign. And then we have to be alert also in the mental health services. So this is streamlined assessment. It's replicating basically a full psychiatric assessment. It's helping in clinical decision making, and it's helping to send people to the right place, because many times people with mental illness, they are sent from one place to the other first to psychological services. Psychological services identify someone has suicidal thoughts, then they say, oh, you know, this is too risky for me. Then they want to be seen by psychiatrists. They have to retell their story each time and are not being helped often for a long, long time. And this is, I think, where we can make a big difference. And here are the conditions that we are assessing in the Censeo platform, which is our diagnostic platform, which is now used in the NHS already. We are in several NHS trusts. We are also in private psychiatric care, and we're just currently trying to roll out into different places as well, where we see utility. We want to also deliver a product direct to customer, where patients can do that in their own place. They can check their symptoms. They can then seek help if they feel ready. And many times with psychiatric disorders, people don't want necessarily to talk to someone. They want to find themselves, can I sort it out myself? But at some stage, with the appropriate psychoeducation, they may feel they are now ready to seek help. So in the Delta study, we looked at bipolar disorder, we looked at generalized anxiety disorder, insomnia, obsessive compulsive disorder, panic disorder, social anxiety disorder. But Censeo, I will not read out everything. We look at almost all psychiatric conditions and cross-reference them. And we've done trials in primary care. We get good accuracy, sometimes excellent accuracy. This is obviously on a small number. We validate regularly blinded reviews of the reports and the outputs by psychiatrists, by psychologists. They look at the symptoms and say what sort of diagnosis they believe these symptoms would be associated with according to DSM-5 or ICD-10 criteria, which are diagnostic manuals that we're using typically in psychiatric care. So we feel that with our product, we're increasing, we are helping to overcome the increased demand that we have in the NHS. Services are overwhelmed, particularly in primary care. 40 to 50% of patients who are coming to see their GP, there's a component of mental illness associated with it, and they don't know what to do. Here, there could be a way of more easily identifying those people who most urgently need to be seen, because we're also assessing suicidal risk. We're looking at self-harm. We're looking at people who may engage in risky behavior. So we're not shying away from severe mental illness. We are really deep in there with the severe mental illness, not only mindfulness and the milder anxiety conditions, but really something, we're looking at psychosis, for example, as well. So we hope to reduce staffing pressure and help to triage patients in the appropriate pathway. Patients can do these assessments in their own time. They can come and go. They can think about the question. They can go backwards as well. And this is sometimes very difficult, because at your first appointment, if you're going to a psychiatrist, you're sitting there, you're very nervous, you're seeing a person you've never seen before. They will ask you all sorts of the most personal things, and to open up can be very difficult. Here they can do that in their own privacy, and they don't look someone in the eye, you know, who they haven't seen before. And this can be something, particularly for men, easier, because we see that many men don't come and seek help until they are very, very, very ill. And hopefully with this approach, we see more men coming through our doors, and we can treat them earlier as well. And this is how it works, the digital assessment. We have our algorithm, we have then a report, and the report is delivered to psychiatric services. So at the moment, our product is used in the NHS by the psychiatric services. So they have people on the waiting list, they send them the link, the patient does the assessment. They can then, the psychiatric nurses or doctors can look at the report. They can see this person is suicidal. Let's call them straight first, so that we, you know, if there is a risk. Some people have milder conditions. They may have some anxiety. They may not need to see a doctor. They may be able to see a psychologist as well. So the clinicians can make an informed decision, because the tool helps to structure the need that presents amongst the people on the waiting list. And unfortunately, in the NHS, this is what we're dealing with, lots and lots of patients on waiting lists, and you don't know who needs to be seen first. And I hope that we will be helping here for patients to get help And this is a report. It has changed already. We're always working, but you can see here information about suicidality, self-harm. Also, the patients can fill in, why am I coming now? What I'm looking for, what type of help? Why am I in a crisis? They can talk about, I am financial difficulties, you know, I'm about to be evicted, I'm homeless, etc. All of this information is obviously very important for us to see the context, because mental illness is not like a broken leg. You need to see the whole picture of an individual who's presenting at a given time with what symptoms. These symptoms have a context and we need to understand them. And then it gives a confidence indication of certain disorder here, for example, bipolar disorder. It outputs all the symptoms related to a diagnostic manual where a doctor would say, okay, yes, that sounds like bipolar disorder, but they can also make a decision. I think this could be something else. So we are not replacing a doctor's assessment. We're just giving structured information. Then the doctor or healthcare professional can themselves interpret. So we are not a diagnosis, but we're supporting diagnosis, in particular the triage to patients to the most appropriate treatment and intervention. And we have over 8,000 patients have used Censeo. We have a very good up to 80% completion rate. In some services, it's lower. So we hope to change that as well by sometimes patients don't know where this link is coming from. So we need to make very sure that they know this is coming from your doctor, this is coming from the NHS. So there are some little tweaks that we have to do. People usually can do the assessment in an hour. Some people need more, particularly if they have lots of symptoms. If you see if they're alcohol use, depression, and lots of other conditions, then it will open up many, many trees of question. And we have a lot of uptime, and we've so far identified almost, you know, as we believe, sort of 100% of the urgent cases. We've saved certainly life as well. And we are making impact. We have looked at the NHS trusts who we are working with, where the product is being used. We can help to structure, we can help to triage patients through the system and really deliver on our promise that patients don't knock on too many wrong doors, and we identify those who need help most urgently. And this is the end of it. Thank you very much, and I'm ready for any questions. Thank you.